Hello, and welcome to this introduction to health economics. My name is Johanna. I worked as a health economist for nearly 20 years. During this time, I worked for different types of organizations, including government, non-profit, consultancy, and pharmaceutical companies. I am currently based in Switzerland, but originally I come from Finland. Why do we need health economics? There are many effective health technologies available, such as medicines, medical devices, and health programs. Ideally, everyone would benefit from all effective health technologies, but that is simply not feasible. Realistically, it is not possible to fund everything. Therefore, choices need to be made. We want to understand how to get most benefit with the limited funds that we have available. Health economics is one tool that can help to decide which health technologies to fund and at what price. We do this by comparing outcomes and costs for two or more health technologies. Let's take a look at the costs. Health economic evaluation includes direct costs, such as cost of medications, or fixed costs, like those related to equipment like X-ray machines, or costs of healthcare staff. Direct costs are the main focus of most health economic evaluations. There are also indirect costs related to lost time at work or school, or caring for a sick family member. Now let's take a look at outcomes. In this short presentation, I only have time to cover the most commonly used outcomes, although it is good to be aware that there are other outcomes as well. Some health economic evaluations do not include any outcomes and are purely focused on cost. Now let's see the outcomes that I use on a daily basis in my work. We do this by considering three different types of health technologies. The outcomes to measure the success of these three different health technologies are also different. A medication may aim to reduce cholesterol. A screening program would aim to reduce colon cancer, and kidney transplant would aim to improve kidney function. How can we compare the benefit that these three very different health technologies can bring? To do this, we need to convert the benefit from each program to what is called quality-adjusted life years. What are quality-adjusted life years, or QALYs for short? A health technology can benefit patients in two different ways. It can increase the number of years that the patient lives, and/or it can increase the quality of that life. A QALY is number of years lived multiplied with quality of life. But how can we measure and quantify something like quality of life? In health economics, we use a scale that ranges from 0 to 1. 1 represents perfect health. 0 is equal to death. Negative values are possible for health states that are considered worse than death. This measure is referred to as utility. There are different ways to measure utilities. In the box here, you see names of some of the commonly used instruments, such as EQ5D or SF36, that can give us the estimates needed for health economic analysis. These instruments are essentially questionnaires that patients, or sometimes their family members or clinicians, fill in. Let's take a look at a simple example of a QALY calculation. If you live 5 years in perfect health, that is with the utility of 1, you have accumulated 5 QALYs. If you live 5 years in poor health, let's say with utility of 0.2, in those 5 years, you would have only accumulated 1 QALY. A basic principle in health economics is to consider how much does it cost to produce 1 QALY. Another important and related concept is incremental cost-effectiveness ratio, or ICER. ICER is used by many decision makers around the world as a threshold to decide whether or not to fund a health technology. It is calculated as incremental costs between 2 health technologies divided by the incremental QALYs. This allows us to understand whether the new health technology is more or less effective and more or less costly than existing alternatives. The diagram on the right helps us to decide if we should fund a health technology based on the ICER. The southeast quadrant represents a situation where the new treatment is more effective and less costly. Naturally, we want to fund any such treatment that saves us money and gives us more health. Similarly, it is easy to decide whether to fund treatments in the northwest quadrant. In this case, the new treatment is more costly and less effective, so we won't be funding that treatment. With the 2 remaining quadrants, a judgment about funding is more complex. Most new medicines fall into the northeast quadrant, that is, they are more effective than existing treatment options, but they are also more costly. How much more should we be paying for 1 additional unit of health, such as 1 QALY? On the graph, we also see this dotted line. This represents the willingness to pay threshold. Most decision makers have implicit thresholds, but some are also explicit. For example, in England, it is considered acceptable to pay up to £30,000 for 1 additional QALY gained. The most complex part of health economic modeling is usually the construction of the underlying disease model. There are many methods available. One of the simpler ways to calculate costs and QALYs is by using a decision tree. The calculation is based on probabilities of events occurring and that these events have different costs and quality of life associated with them. Another common method is to use a macro model, where we simulate patients' health states in defined model cycles. Patients have a certain probability to stay in their current health state. They can also get better, they can get worse, or they can die, for example. ICER will then be calculated to estimate the total QALYs and total costs in each treatment option. Finally, let's consider health economics for a fictional new treatment. In this cartoon, a doctor is holding up an X-ray result and says, "Your X-ray showed a broken bone, but we fixed it in Photoshop." So now we have a new treatment option for broken bones, Photoshop. How cost-effective you think Photoshop is compared to surgery? If we revisit the graph that we saw earlier, we can estimate in which quadrant Photoshop would be as a new treatment option. We know that it is likely to be a lot less effective. It's probably also less costly. But I think that most of you would agree with me that Photoshop as a new treatment option is likely to fall somewhere in this half of southwest quadrant, and therefore it cannot be recommended as a treatment option to fund. This was a little bit of an unrealistic of what new treatment option would look like, but nevertheless, it serves to illustrate how health economic models can be used in policy and decision making. Health economic models, like all mathematical models, are simplifications of reality. Even under optimal circumstances, they are associated with uncertainty. However, health economic models can be an extremely useful tool that can help us to allocate precious resources. And with that, I would like to thank you for your time and attention for this short introduction to health economics.